Thanks, Dr. Arruda. We have quite a few questions, so we'll start with this one, which I think is very appropriate for our audience. As doctors, nurses, healthcare providers, and healthcare managers, what is our responsibility for patient education? How far should we go? How do we best divide our time between data analysis and being doctors and providers?
Well, I think people are not so much dividing their time, but they are focusing on one or the other more commonly. Um, I think we figured out that in surgeons, for example, it's you're not going to be as good a surgeon if you do 25% surgery and 75% patient education and research. And so I think people really do one thing quite well. On the on the day-to-day though, I think you do spend a lot of time in patient education, and it goes a long way when they hear it from their surgeon themselves. I mean, there's use for PAs or nurse practitioners or whatnot, but really if I'm going to apply a knife to someone's abdomen, they deserve to have heard what was going on for me.
So there's another question here about the NSQIP database, the National Surgical Quality Improvement Project database. Is it possible to have an insider or friend at a hospital research that for you to get a little more inside information on a particular surgeon?
The NSQIP database does not break it down by surgeon name. So, for example, we will find out from them, your hospital has done 500 hysterectomies this year, and rate of urinary tract infection is 3%, and your rate of, postoperative bleeding requiring transfusion is 10% or whatever it is. But it does not give you an individual surgeon's name and then their personal complication risk. And I mean, I think that makes it harder for patients to choose a surgeon because they don't necessarily care what the hospital risk is. They care what my complication rate is. And trying to get that pinned down to an individual surgeon is really difficult.
So it's the NSQIP is really only useful for comparing hospitals, not physicians.
That's
and
correct.
Then if you can actually have someone get into the database for you, and I presume then that the database is accessible to anyone with the credentials to look at multiple hospitals, not just any one hospital they might be employed by. Is that correct?
That's correct.
Good. We also had a question about the ProPublica surgeon scorecard. What if I'm a surgeon who has an issue with my report? Is there any redress for that sort of thing in the ProPublica?
So I looked in that because I was curious, and they actually, the way that they do the surgeon scorecard is they actually have a series or a panel of physicians in that specialty. So for example, urology, they would have 5 or 6 urologists who then review the cases that are associated with that physician. And they are, at least online, very committed to transparency for the surgeon. And so they have a contact method for the surgeon to sort of see what's going on here. Because you're spot on, if you're a surgeon that takes higher risk patient, now all you're getting is this black mark on your reputation from an online site to be able to have some contribution. ProPublica seemed a little bit more transparent in responding to surgeons' concerns than, say, some of the health grades or the patient-driven ones.
And this is a related question on that in that same vein. How do I, as a surgeon or a healthcare manager, respond to a patient who's concerned about Yelp reviews I feel aren't particularly accurate?
I think as a physician, our hands are tied in that way. Oftentimes we know something that occurred, say, in the visit that is not necessarily, like, so for example, a patient will come in and we will have a discussion. I'll offer her some options that are non-surgical. And then she'll be unhappy with my response. And then she'll get online and sort of ditch me on one of those sites. And I don't have an ability to respond online because of the HIPAA violation that would occur if I exposed her medical problems online, right? I don't know that we have a way of, as surgeons, of responding to the online sites that are patient driven. I do think we have some routes to respond to the ProPublica type scorecards.
And if I could, I would like to add, we did have a webinar on this very topic earlier in 2015, I believe it was summer, and that is on our website for any of you listening. If you are a registered user in today's seminar, you should be able to go into the section on our website with your username and review some of those the ideas we presented for responding to those kinds of reviews. Which leads us to another related question. You were calling Yelp a pretty reliably source of ratings of physicians, given Jeffrey Siegel's study. So, what kind of grade would you give to the to sites like Yelp? Is it an A minus, a C plus, or is online reviews of doctors D or F?
You know, before I researched this presentation, I'd have given them an F, because my impression colloquially is that I think dissatisfied patients tend to get online. Like my mom, she's going to get a free ticket from United Airlines if she complains to United Airlines, but when she has a good experience, she's not going to be like, yay, I had a great experience, I'm going to rate them online. However, when I looked at the data, it actually doesn't pan out that way. I do think Yelp or any of the, that Paul Seeger study looked at a bunch of different sites, not just one. The number of ratings, regardless of whether they were good or bad, was higher in high volume surgeons. And so I think if you're a patient, you know that you can reliably say the people who have a lot of comments or a lot of ratings probably do a lot of surgery. And that's probably all we can take home from that.
So to put you on the spot for a little bit here, Dr. Arruda, would you personally rely on Yelp or similar sites for choosing a physician or surgeon for you or a loved one as a factor?
I would look to see if there were reviews, yes. It's easy for healthcare professionals because we can go to work and just say, who's good at this? And then someone tells them what they look like in the operating room on a day-to-day. But I think knowing what I know now, I would certainly look to see, hey, has this person gotten reviewed?
Yeah. Here's another good question from one of the participants. If you are a surgeon with high complication rates, how do you explain them to potential patients? What do you say to them? And I'm assuming there's sort of a built-in assumption here, that is, some physicians take on the most difficult cases.
So I think that's why I would, as a surgeon, it's our responsibility to know how many cases we've done of a certain variety and what our complications look like. So, I mean, the first step of insight to that is to really look at what your complications are as a surgeon and say, hey, am I approximately on par with the rest of the world? And then if you're not, we have to look and say, oh, look, yes, this year I had a higher complication rate, but when I look at these complicated patients, I see, this lady had a BMI of 62, and this one had a, heart transplant before her hysterectomy. And you need to really be able to justify that your complications are indeed due to a higher complexity of patient care, and not just, I'd like to think that. And then I'm pretty honest with my patients if they were to bring that up, just to say, here at University Hospital, we take care of a little bit more complicated patients. And so, sort of in the vein of not turning people away who've been turned away from other places, we're willing to accept a little bit higher complication rate than the average. But I think it's important to be honest with yourself first.
What is your general philosophy towards encouraging second opinions?
If it is something that's going to make you decide whether or not to have surgery, and you have the cushion of time to get a second opinion, it is definitely worthwhile. I mean, half the time I give a second opinion and the patient ends up having surgery with me, and about half the time I give a second opinion and the patient ends up having surgery with their first opinion. But sometimes they just need to know, I feel like two brains are better than one in making this decision, and I've gone to see two different people. And I do encourage people, if they have the luxury of time, it's not something that's life-threatening, or, they have to have surgery tonight, that a second opinion is worthwhile.
Very good. Okay. Well, we have another minute or two if anyone wants to submit other questions. Otherwise, we're, I think, our time limit. I want to also point out that there is a wonderful blog on Dr. Arruda's website for department entitled something to the effect of seven questions that patients should ask about surgery. And they're very guideline for any healthcare provider, healthcare manager, in terms of being ready to answer really tough questions. So I recommend you to obgyn.coloradowomenshealth.com, and then look for the blog button in the navigation at the top. It's in one of the drop-down menus, and it's a very well-written blog, and one that I will use next time I'm considering surgery for myself or a loved one. So again, that address is obgyn.coloradowomenshealth.com. And you can see two other blogs written by Dr. Arruda and her colleague there, and I think they're one of the standouts in the world of patient education and online patient education, especially. There's a wealth of really good information for OBGYN patients and reproductive medicine patients. So it doesn't look like we have, oh, here we go, one more question. You have other physicians that you refer patients to for a second opinion. I think the implication there is, should you have, a list of a handful of other doctors that you feel comfortable sending patients for second opinions of any kind?
That is an interesting question, because I think some patients prefer to get a second opinion from someone who I think is good, because they've come to me and they trust me, and they say, who else would you have operate on me? And other patients prefer to have a completely unbiased second opinion, and they would be wary of me referring them for a second opinion to someone, because they're going to assume that I'm on the same brainwave as that person. So I will often ask patients, do you prefer that I give you a name for a second opinion? Because obviously I would know people who would operate like me, or might have the same skill set or the same head on their shoulders that I do. But if they prefer to look on their own, I try not to push it, because I think a true second opinion is often someone who's coming in completely unbiased to the patient.
And do you have any, the follow-up question, do you have any suggestions on how you respond if that patient comes back with a report that the opinion was radically different from yours?
So a lot of times that will occur if they seek a second opinion with someone who's like way out in left field. And I never mind sort of acknowledging that. Like, so for example, I'll see a patient for something that's probably benign, and she's young and she has very few risk factors for anything cancerous, and then she'll go see a cancer doc across town who generally sees patients that are much sicker and everything they look at is cancer. And so I would never be afraid to tell the patient, look, you've gone to see a cancer doc, so of course they think you have cancer, but statistically you don't, give my opinion. But it actually pretty rarely occurs.
Well, that's good to hear. Okay, I think we are about the end of our time here, so thanks to everybody for participating today, and especially to Dr. Arruda for a very, very insightful presentation. Anyone who registered for this webinar will receive an email with access to a recording of it, as well as to past webinars. And if you've attended a Vanguard Communications webinar before, your past will still work to access the recordings. Be sure to take the survey following the presentation, and encourage others to sign up for the webinars series, as well as for Vanguard's newsletter to learn about upcoming webinars and the Pathways to Prosperity series. Our next presentation is scheduled for March 17th, and it will be on healthcare security, a really big topic these days with some famous security breaches such as Anthem and the U.S. government and so on in regards to health records are getting more and more spotlight. So be sure to watch your emails for more information on that. Thank you again for joining us. This concludes the webinar this time, and have a wonderful weekend. I look forward to seeing all of you virtually on March 17th for our webinar on healthcare security.